Hello.
Right.
Hey guys, it's Jay and Monica.
Hi.
So guys, we today's show is going to be about testosterone replacement therapy. Also, Dr. Leonard Farber is there with us. Say hi, Leonard.
Hello, Leonard.
That's even better. So guys, today's show is about testosterone replacement therapy. It's mostly for men, but if there's any questions that we field for women, that's okay too. We really want to talk about from a standpoint of, entry level. What does a person do? Why would a person need testosterone replacement therapy? What's the purpose for testosterone replacement therapy? How would a guy go about getting on testosterone replacement therapy? And just kind of field a lot of questions. And I have tons of questions to answer about that. But with that said, we are in Florida right now. Woo! Doing a photo shoot for our next, the second iteration of Brett's book, which we are helping him author, which is Get Serious, Volume 2. And that's going to probably be on newsstands and everywhere available on the web by probably, end of this year? Yeah. Brett's here. Say hi, Brett.
Hi, Brett.
Well done.
Sorry, Leonard, I stole your...
Hey, listen, anyone can,
Hey, we hang out with the coolest of the cool.
That's right.
So, Scott, as far as right now, how does it sound? Is it really distorted, or are we okay?
It's a little distorted, but it's fine. It's working good enough.
Yeah, I mean, obviously, unfortunately, I don't have the normal set with us and audio and stuff like that. And Ray's here too. You want to say hi?
and I'm going in and out of video on purpose, so don't panic.
Okay.
Yeah.
No problem. Hey, everybody. Yep, Ray's here.
Hey, Ray.
How you guys doing? What's up, Doc?
How are you?
What's up,
Yeah.
Ray?
Cool. It's okay. So, the topic is, again, it's TRT, everything you wanted to know. I'm trying not to be crazy here in the background. We have a lot of stuff going on in the background, so hopefully it won't be that distorted. But so I think the first thing we can really start talking about is the book. And Dr. Osborn has helped me a lot with this book immensely. Been writing it behind the scenes for a long time. The book is going to be coming out, I would say, by middle of May, maybe June 1st at the latest. The book is going to be, as it's titled, the definitive testosterone replacement therapy manual. It's a book that is written for men and doctors. Okay, so it's lay, as far as it's basic enough that any man can read it and understand it. And it really is just the type of book that anybody who's in their late 30s and really even in their late 20s, but we like to try to center it in the late 30s, who's feeling a little bit down, maybe depressed, maybe have lack of energy, loss of libido, a number of different side effects or feelings. So what do? Well, the first thing to do is get your blood measured, and from there, then determine if you can be considered as a patient for testosterone replacement therapy. Okay. And I think that it's unfortunate in our society today that testosterone has become a really, really taboo subject, and there's too many men that have low
Hey,
testosterone.
Leonard, is he cutting it out for you too?
I can see you.
Yeah, I mean every like third or fourth word you're cutting out right now, almost.
Well, I don't know what to do. I mean, this is the bandwidth I have here.
I hear every word.
Yeah.
So it's not on my side. Maybe it's on your side, Scott.
It's not on your side?
No, I hear him. In fact, I don't even want to hear as much of him as I am hearing.
All right. Well, maybe it's me then, Jay. Forget it. Just keep going, buddy.
Okay, cool. So anyway, back to the TRT, I think it's the easiest way to, again, the book is going to be a really good explanation. It's going to be a very authoritative resource for people to purchase and to figure out, step one. But what would you say, Dr. Brett, is step one, for, let's say a person presents to you who's a 35-year-old guy and he feels like he has a loss of energy. What would your first steps be?
Right. So a lot of the patients that come to my office just a priori come by virtue of the fact that they feel that they are in need of testosterone replacement. So they're exhibiting the typical symptoms of hypogonadism, and that's fatigue, an inability to maintain or put on muscle in the context of exercise, decreasing libido, abdominal fat, adiposity, whatever you want to call it, These are all signs of hypogonadism. And typically the way we get them worked up is by ordering, in addition to doing a physical exam, we order a battery of endocrine and metabolic tests, which are pretty standard. And it's almost like a stamped prescription in my office. And basically it assays free and total testosterone, estradiol level, sex hormone binding globulin, luteinizing hormone levels, follicle stimulating hormones, LH and FSH, to see if there's either a primary or a secondary cause of the hypogonadism. So whether or not it's something that's central in origin from the hypothalamic pituitary system, or secondary, which is primarily from the testicles themselves, and you can sort of discern between the two of them. The only reason why you would have to theoretically do something like that would be because in a small, very, very small percentage of patients that have hypogonadism associated with pituitary and hypothalamic dysfunction, so something going on in the brain, there's a small percentage of them that are going to have tumors in the brain, and this is something that would potentially prompt an MRI of the brain. That said, that's usually not the case, and we don't end up ordering MRIs of the brain in these patients. But nevertheless, if there's some sort of clinical suspicion, then we do. Typically, it's not the case. And there's age-associated decline of testosterone for a variety of reasons, but it's not typically the result of some sort of brain tumor or pituitary tumor. After that, we bring the patients back usually 7 to 10 days later, when we take a look at their hormone profile, and then we make the necessary adjustments, additions, supplement. We can start out with something that's less aggressive, like dietary modifications, some of the sort of low-level supplements or testosterone stimulation drugs that we use, like beta-HCG, which I don't use often, but in a subset of patients I will. If somebody's of childbearing age and they're floridly hypogonadal, then I will potentially put those individuals on HCG if everything else that's more conservative fails. I'm hesitant to put anybody that's of childbearing age on supplemental testosterone as sort of as first line, because one of the side effects of testosterone is the fact that it can lower your sperm count. That being said, you can be on testosterone even during your childbearing years, and you run a fairly low risk of developing sterility, because typically what you can end up doing is you can end up doing rescue therapy, which is a lot of times what bodybuilders do. So it's not definitely an exclusionary issue, one's age, but I'm a little bit more hesitant to start individuals on supplemental testosterone if they are intending on having children, as opposed to trying something like beta-HCG and a low dose aromatase inhibitor. But that's sort of just some basic stuff that we do just to start.
Yeah, to Dr. Osborn's point, and I want you to jump in, Leonard, here in a second, but to Dr. Osborn's point, I actually, my ex-wife and I conceived both of our children while I was I was a TRT patient. So there's no doubt that you can use supplemental testosterone in a clinical dosage setting with the right TRT dispensing physician, and still father children or still be able to be. Yeah. So I mean, yeah, exactly. So there's I think that the hang up or the taboo or the thought process that many people have about using testosterone is going to shut down your natural production or screw up your reproductive system is really not true. And as Dr. Osborne did say, and we go over this in the book heavily, there are medications that a man can use along with the TRT that will make sure that they remain fertile. Leonard, you got anything to say? I think he's got you on mute real quick.
I'm here. Yeah, no. I'm here. I actually had a question for Dr. Brett. Do you get PSA tests on your male patients before you put them on testosterone?
Yeah, I do, Leonard. I mean, as much of a sort of a defunct test as it is, and you can speak to this more so than I could because it's your subspecialty. But I do, and I have become less and less worried and concerned in my follow-ups, just based upon the the data that's come out over the past whatever it is, 5 years or so. And obviously, you're very, very well versed in this, much more so than I am. And here's basically my treatment paradigm. What I do is I will get a baseline. If somebody has an elevated level, okay, what is deemed elevated, and we don't really know what that number is, as you know. I will potentially tell them, and this is, it's one route that I go. I say, okay, listen, we want to get a repeat study on you. Okay, I don't want any sex. Okay, for 3 days before you get tested, and we'll have them come back. Okay, and retest. If it's still elevated, then what I'll do is I will typically, because it's not my forte, and I haven't done enough of them except in the context of spinal cord injury, send somebody for a rectal exam and actually formally be seen by a urologist to see if there are any concerns. You can go as far as getting, as rectal ultrasounds, and you can actually measure the prostate volume. You know about this stuff much more so than I do. But these are some of the things that are being utilized by anti-aging physicians. If PSAs turn out elevated. Now, if it comes back and I get a normal exam by the urologist and it's clean, then I'm very, very comfortable. Even if the PSA is 6, 8, it doesn't matter. Okay, as long as there was no, well, we better biopsy this individual. We're concerned. There's something that's suspicious. I'll go ahead and use it and I'll follow it. And I will tell you that in my experience, which as you know is pretty extensive, what ends up happening with these patients' PSAs, and I'm sure you can testify to this as well. It either stabilizes, and I have plenty of patients who actually the PSA actually goes down. Right. Down. So, and you probably can to testify to this as well. I will tell you that my PSA is the last time I think it was checked, I think it was 2.8, 2.9, something like that. And I go, and my guy always insists on doing rectal exams, and I will tell you that in the years that I've been on TRT, my PSA has never budged, ever. And we all know this, and Jay talks about this, right? Jay talks about this in in the book, and we all know that there's some sort of I forget the term that you guys use to describe the saturation. So we know that this is not some sort of there's no oncogenic potential, because if there were to be some sort of tumor, it would already have happened at very, very low doses of testosterone that you've been walking around with, levels of which you've had since you were younger. Right. I don't. There is. That's just that's complete BS, and we both know that. That's
kind of the point I wanted to get to at the end of all that. So yeah, I agree.
Right. What else do you have to add, Leonard?
Yeah. So like with your patients now, what would you say the percentage of your patients, prostate cancer surviving patients, ones that have had the tumors or the cancers removed? What percentage would you say are actually you recommend that they use TRT?
Well, for as a tool for following patients, every patient who's had prostate cancer needs to have serial PSAs. And that's very different than using it for diagnoses, because a PSA for diagnoses is not as accurate as it is for following after treatment. So we're only talking about patients who have no history of a diagnosed prostate cancer. Right now, PSA is really the only real tool we have. There is a urine analysis test called a P3, a PC3. It has some validity. The way I look at it is in combination of the whole picture. You look at the patient's age, you look at their prostate exam combined with their PSA. If you have a nodule, you bought a biopsy. That's just how it works. Right. If you don't, then I look at what the trend in is at their level, and their levels is age related. I just really like the idea, as Brett does, is to just get yourself a baseline PSA, because, well, one, as a physician, I know this show's going to a different slant, is you really want to know what your patient's coming in with. For the rare patient that may have an undiagnosed prostate cancer, you just don't want somebody coming back saying, hey, why did you put me on testosterone without checking? But for the most part, you see what their level is. If it's out of the normal range, you say, go to the urologist, get checked out. Urologist does an exam. The big change now in screening has become the use of these 3T MRIs. And at a good center, they do it with ultrasound fusion, and you can really pick up discrete prostate cancers by an MRI now. It's not replaced PSAs, but it is a good indicator. So that's not something you have to worry about, but the right steps is if somebody comes to you, you get a PSA. If it comes back elevated, you tell them, here's what you do. Go to your urologist, make sure you get an MRI, and just get the clean check off. But once they're on TRT, having no elevated PSA coming into it, I don't worry about it. I mean, I check mine every 6 months, and it has not budged ever. In fact, it does come down a little usually when I repeat
Mine's
it.
actually come down a little bit. It's crazy.
Yeah.
Leonard, let me ask you another question. And we're getting off a little bit, but so in your patients that have treated a prostate cancer, and I'm not talking about patients that have had radical prostatectomies where they have very, very little prostate tissue left, but they've had just brachytherapy or seeds, or and their PSAs are non-existent at this point.
Yeah.
You okay putting them on?
Oh, yeah. I mean, I've actually referred lately what I've done, and more so because it's not my main focus as it is yours, but I have enough that I work in conjunction with urologists. I've had several patients that now these patients still follow with their urologist. I've had several patients that I have sent to the urologist with the recommendation to put these patients on TRT.
Oh. Mm-hmm.
I've had a few that, because their PSAs have been so high, sometimes I'll say wait 2 years because that's sort of the standard. But for patients who are experiencing such low testosterone levels after treatment that their quality of life is so bad, I've had patients go on after 6 months of radiation.
Right, but the thing about it, Leonard, is that the patients that I've had, and again, this is not my subspecialty, but I do have my share of them. They get put on Lupron and they get put on all these other, and it just does the exact opposite. And then you have a real issue. So what do you do in those cases?
Yeah, it's a real problem. I am less inclined to use Lupron now for low and intermediate risk prostate cancers. For intermediate and high risk, they get Lupron, except actually with a new technique that I've been doing. It's called SBRT. It's body radiosurgery. Mm-hmm. So it's a 5-day radiation course instead of 45 days. And it's the high dose, the intensity that eradicates the prostate. And the last study that was presented for these high-risk patients that would normally get Lupron, they did just as well without the Lupron with the 5-day course. So sometimes what I would do is, if you see these patients, is actually discuss this other treatment option for them if they're not on Lupron. If they're on Lupron, that's a really tough case because you're shutting down the conversion of testosterone to DHT completely, and you're putting the prostate really into non-functioning mode. We don't have that much experience with patients getting Lupron and then adding testosterone, but they're not doing the exact same thing. It's not a contradiction in biology if you think about we're just increasing circulating testosterone. We're still not converting it to ADT. What that experience is, I don't know. I honestly, most of the patients who are high risk on Lupron only stay on it 2 years now. It used to be 3. Some still do 3. Intermediate risk, they're only on it for 6 months. So the idea is, let's stop after 6 months of treatment and then start testosterone. Your challenge is these patients who are on it for 3 years. Oh, you guys there?
They must have bounced off. Hey, we can't hear you. You're on mute, Jay.
They're frozen.
We're on mute?
No, there you go.
Still?
No, you're good.
Honestly, it just literally just shut down on us. Anyway, continue, Leonard. Sorry about that.
Yeah, so I don't have any experience of having patients on Lupron and testosterone at the same time. Have you had any?
No, I could just tell you that I was just wondering what your thoughts were. In other words, just I guess see, I don't know the indications for starting individuals on Lupron, so that's why I was asking because men come to my office and they're basically not men anymore; they're females.
Yeah. Oh, it's
awful.
But you know what? This is a good question set up for me for the next talk. I would love to figure that out because there are plenty of guys out there on Lupron with testosterone levels of essentially 0.
Yeah.
And I will actually do some due diligence to see if there's any literature out on that. So we can.
Curious. Thanks, Leonard.
Yeah, you got it.
Awesome. You got to go? Are you okay?
Yeah, I'm going to go.
Okay. Thanks for showing up. I appreciate it.
Yeah. Next time I want to be invited to this photo shoot. That's my prep now is for a photo shoot. We all need small goals.
Exactly.
So
you're always invited. I mean, you got to practice to run and all the other things you do, but you're always invited, my brother.
Yeah. Next one.
Okay, man. Well, thanks for calling out.
Hold you to that.
I appreciate it. All right, cool, Scott. So Scott, maybe I got a million questions here, but I wanted to maybe shift to you a little bit here, because I think you're perfect. I think maybe looking at Scott, right? He's a 32-year-old guy. What would if the 32-year-old guy? So Scott, you take over, right? Like you tell us like your thought process if you were to consider going on TRT. What would the questions?
Yeah, well, I mean, I guess like being someone that's not super knowledgeable about it, the first thing I would do is I always for me is like finding a doctor that I can trust, right? So that would be always the first step for me, and then from there is, well, obviously I got to get blood work or panels done, what you guys are talking about to figure out.
I think Scott, the first thing that you should do before you find a doctor is you should start reading.
Right.
Okay, and that's really the underpinning of of the books that of Get Serious and of Jay's book and of the new one that's coming out. I mean, the better educated you are as a patient, the better you're going to be able to serve yourself ultimately, and rely less on your doctor. Yes, you do need to have a doctor in whom you're confident, but more importantly is the fact that you go to that doctor and ask pertinent questions. Having educated yourself. Well, so I think that's extremely, and that's number one, number two, and number three, and then number four is go to the doctor.
Yeah, I think though, to Scott's point, Scott, and not to plug the book, but it is hard for younger guys to find really good information. The internet is littered with like lowtestosterone.com and low T center clinics and all this stuff. It's ultimately nonsense, and it's hard for people to like figure out, especially guys your age and even guys who are older than you, whether they're getting reliable information. So I can definitely tell you that my book, it's really our book, when it comes out, will really do an amazing job for a kind of like a casting a real, a bright light on a kind of a dark / nebulous subject. And it'll be a book when you buy it, if you know nothing, like yourself maybe, or, and you know more from being on the show than the average guy does. But if you know nothing, you could buy this book and you absolutely can read it in, 2.5 hours if you're, a pretty good reader and you have somewhat comprehension of the subject. And from that book, be able to make an informed decision, okay? It really is written for every man to be able to understand it, but there's definitely some molecular biology and endocrinology in the book, but we really lay it out and break it out so that it's understandable and that a person who doesn't want to read that can kind of like skip that and push ahead to the stuff that really applies to them individually. That's
good. It's good. Because half the time I don't know what the hell you guys are even talking about.
Right.
And you're not alone, Scott, at all.
Yeah.
And that's why I always try to push my patients in the direction of education first. And once you start reading it, provided you're reading the right information, it's not very difficult. You don't need to be a doctor to understand these things. You really don't. They're just some basic tenets. And once you understand it, then you don't have to think anymore.
Well, one of the problems, and I think this is a good segue, with TRT in North America, and as we find out, and the book gets more viral and more people internationally find out about this, it's a global situation. And the problem is that, testosterone has been demonized. Again, at the end of the day, testosterone is a class 3 controlled substance by the DEA. And so people look at it as, sometimes, unfortunately, as a drug, and it's not a drug. It's a hormone that men naturally produce that as we age is reduced and cessates in your body. So as you get older, you have less and less testosterone. But testosterone is literally the essential lifeblood for men. And when you don't have enough of it, you're, as Brett just said, you become less and less a man. I mean, you're emasculated, you lack energy, you have a mental fog. There's a million side effects and a million effects systemically that affect you as your testosterone gets lower and lower, and it's not something that any man should have to suffer.
That's great. Yeah, I mean, is there anything else that you want to say about it? I know part of this show you were going to talk about how someone could go step by step if they wanted to work with Dr. Osborn. I know that you wanted to go over that.
I think we could probably segue into that. I have so many questions. I was trying to contemplate whether or not some of these questions.
Well, yeah, definitely answer some of them if they've been asked. Yeah.
I think no, but I think the questions we can come at the end. I think so. It's a great question. So the question really is like, how does somebody? So you're somebody out there. You watch our show. You read the transcripts. You know, a friend of a friend says, "Hey, you know about our hangouts, FabFit Over 40, Dr. Brett Osborne, Dr. Leonard Farber, blah blah blah." And you want to contemplate. The first step, obviously, as Brett just said, is to educate yourself. Okay. You have to figure out, you have to have a small, lay understanding of what you are looking to accomplish by using TRT, right? You can't just get your blood measured and the blood labs come back and says you have low testosterone and then figure out you're going to know what to do, right? Because just because you have low testosterone could mean a number of things, right? So the first step is education. Read as much as you can online, and then you might not find all the best information. There's a lot of hodgepodge stuff on the web. If you read our site, and if you go to dangerandplay.com and you click on TRT podcasts, that's a great resource, okay? Mike Cernovich of Danger and Play and I have done probably 7 or 8 TRT podcasts in the last 15 months, and the information in there is gold. You can Google that, Danger and Play TRT podcast, and it'll come up. There's plenty of information in there, starting out stuff. But to answer the real question, like how do you work with Dr. Osborne? There's a couple of ways. Obviously, you can go to his website. It's drbrettosborn.com, okay? You can go to our website, okay, fabfitover40.com, and you can basically submit, a contact form saying, if you go to our website right now, and I'm not going to show up, but if you go to fabfitover40.com, again, it's FABFIT over 40.com, and you click on Consult with Dr. Osborne, it'll send an email to me. You're going to have to tell me, who you are, what your name is, what your phone number is, and then, a comment about what your situation is. And from that, okay, you will then be put, if you seem like the right type of patient, you will be put forward to his nurses. And then his nurses will then reach out and contact you and figure out, your individual situation, your individual presenting symptoms, who you are and whatnot. And then if they determine that, you possibly could be a candidate for TRT, what you have to do is, and this is based on the law, is you're going to have to fly into South Florida, either Fort Lauderdale or West Palm Beach, and you're going to have to visit with him. You're obviously going to be having an appointment set up with his nurses. His nurses are awesome, but you're going to have to set up an appointment with his nurses, and then from there, you're going to be clinically evaluated by Dr. Osborne. Anything else you want to add to that?
No, actually, I really don't. Scott, I don't really have anything to add because Jay has been extremely instrumental in sort of streamlining this process for me. In actuality, I hadn't had anybody doing it for me before, and it just so happened that we established this bond, and it's worked quite well. And I'll tell you that it's almost better if individuals go through Jay and Monica's website to get to me, because he's sort of in his presence. Is much more sort of well established on the internet as far as the media is concerned. So I'm out there, but I'm not as out there as I should be. And Jay has been extremely instrumental. And his website, his blog is a tremendous resource for individuals, and he's a tremendous resource for individuals. So yes, people can call my office and talk to my nurses directly, and they will. They'll order the appropriate labs. If the clinical history sounds reasonable, it's unusual when we turn somebody away, but we will be able to direct them and give them guidance, sort of in the context of whether or not they should have labs, whether or not they appear to be meeting criteria, et cetera, et cetera. But I will tell you that Jay does as good of a job as my nurses do vetting these individuals for me, just from the standpoint of he's concerned and he's he cares for individuals, particularly the health of these individuals, and he's well aware of the tools that we can use as physicians to help these individuals. Now, and this just does not apply to males; this applies to females as well. So to go through Jay first. is probably the best way to get to me. And he and I are very, very close contact with one another, on a daily basis. And he's in contact with my nurses, again, just out of, wanting to route these people to somebody with some knowledge and some skills with regard to, TRT. Because, he's been through it, and, he's well aware of the fact that there are physicians out there that are practicing this just from the sheer standpoint of money, because a lot of it is cash pay, and it's not something that's oftentimes covered by the insurance, at least without a significant fight. So that's another issue with TRT.
Yeah, I mean, I think that just to add to what he's saying, and make this really clear for everybody, because we're clearly going to index this on Google as high as we can so people can get really honest to good information on TRT. You must fly in and be physically evaluated by Dr. Osborn. Okay, there's no online consultations. Okay, you're not going to call me or email me or text me and say, hey, you know what, I want you to set up a consultation with Dr. Osborn. I don't care what it costs. I know he's the best TRT doctor in the world, and by the way, he is. But the reality is that you have to take this as a serious medical step. You are going to fly into Florida. You are going to visit with him. You are going to be evaluated. Obviously, he's going to evaluate your blood panels. He's going to look at you, and he's going to, based on your individual workup and your panels, to find out if you are actually a potential clinic, a potential patient for TRT. Okay. Now, go ahead.
I just got a question for you guys. So, looking down the road, years, let's say from now, as hopefully TRT becomes more, I guess, I don't know what the word is, but
in vogue,
more understood, maybe more understood in the medical field. Are you guys planning on maybe having a network of recommended doctors that also work at a level of Dr. Osborn, to where you can expand this network that you're starting to build already?
Right. And it's a very good question. And this has been attempted. It hasn't been the most successful venture for those that have attempted it thus far. And I think that there is at least with me, I'm concerned about doing things like that, just from the sheer standpoint of sort of the efforts being diluted when you go and you expand, as far as quality is concerned. Right. And again, this for me is not some sort of money-making racket like it is for a lot of these other TRT physicians and who get into it primarily because it's cash pay only. And there's a lot of money to be made, particularly on the prescriptions for HGH, or human growth hormone. So for me, I think that when you start really almost franchising yourself out, that's when quality tends to suffer, and it becomes a bit more, just by virtue of the fact that it's diluted. So there have been thoughts, but I sort of at base level have my issues with doing something like that. I guess if physicians were appropriately vetted and put through the proper training, I guess it's a reasonable thought. One of the things that I always tell my patients, or I don't tell them, I just sort of show them, is that when you go to a TRT physician, you don't want to go to the fat physician who's clearly not sort of walking the talk. Right. And I do that, and you can see that on the cover of the book. So ideally, we have to screen individuals physician-wise, not only from the standpoint of their knowledge, but from the standpoint of whether or not they truly practice what they preach, because otherwise it's just more of the hypocrisy. And I don't like that. And if you go to TRT physicians and you took a sample of what these individuals, how they just sort of appeared physically, whether or not they they have this look of health, you'll find that probably about 50% of them just don't. Right. That's already that's a big strike from my standpoint.
And that's an understatement. And honestly, Scott, your question is great because, Dr. Osborne and I have formed, as you know, SOAR, which is Serious Optimal Anti-Aging Regimen, which is a seminar that him and I are going to be putting on along with Ray and some other people that are part of our group. And in order for us to really scale our business, that would be something that, Brett and I would really look into. The problem, as he already really hit, is, it's very difficult to set up technically what would be called a surrogate training program to get the right people that, Brett and I would vet as being the right guys to, promote and obviously, at various points if their doctors prescribe our protocol or something along our protocol.
Yeah. Well, I think as you guys get yourself out there more and this grows organically,
right.
I think you'll have the people that are serious and really into this as well coming to you. I agree.
That you're right. I mean, that's the goal. But again, at the end of the day, as Brett said, it's been tried. There's guys trying to make money. There's a lot of TRT clinics and centers, low T centers, and all these idiots across America. And no offense to them, but it's like Brett says. I mean, if you're going to seriously undertake, a program to improve your health, and that involves you changing your diet, incorporating foundational strength training movements, avoiding injury, sleeping better, clearly all the things and all the components that you need to take charge of your health so that you avoid disease as you age, you better be working with somebody who can train you in that regard, right? And that's what SOAR is. I mean, SOAR to us, and we don't know of anybody, and if there is somebody out there doing what we're about to do, good on them, but I don't know of it. We've done a lot of homework. But, that's the goal. I mean, as Brett would say, if people that went to SOAR were the norm, hospitals would shut down. Okay, because people go to hospitals because they don't take care of themselves. They don't eat right, they drink too much alcohol, and they don't exercise. So all of those three things lead to your body breaking down and decaying. And all of the concepts or all the products of aging, which he talks about a lot in the book, and we talked about in probably 5 or 6 of our hangouts, is component or part and parcel of that lifestyle of living a poor lifestyle, a lifestyle that you don't make conscientious choices to improve your health. So. To segue it back to the TRT, I do believe what you said is right. As people become more exposed to what we're doing, there will be some good doctors that Brett and I are not aware of. And there are plenty of good doctors out there. Don't get me wrong. Okay. There are plenty of guys out there that do, walk the walk and talk the talk. We just don't know them. And when I say plenty, there's probably 10 maybe, but there are some guys out there. And so, I think, just kind of thinking out loud, and obviously Brett and I have had these conversations, it would be awesome if we had a guy on the West Coast, if we had a guy in the Midwest. Obviously, we have Brett in the Southeast and in the Panhandle area, and then maybe a guy like Dr. Farber or somewhere up in that region, so that we technically had all 4 corners of North American continent, with a doctor that, we could say, go see him, you know what I'm saying? Because it will cut down on people's air flight, and costs like that. And then a lot of times too, and Brett and I know this because of talking to people, the mindset is unfortunately that people want to have a local doctor. Oh, I want to go see my doctor in case I get a torn thumbnail or I get the sniffles or whatever. So it's hard to overcome that boundary. But I think that the smart, educated, progressive, forward-thinking TRT patient realizes, because we're dealing with a lot of these guys now, that it's worth it to spend money to fly into Florida, to be evaluated by a physician the caliber of Dr. Osborn, because again, you only have one life, man, at least that we know of. And if you're not valuing it, and you're not trying to age gracefully and physically, stop or slow down the processes of disease, then what are you doing? You've got your priorities wrong.
Yeah. Wow. Absolutely, man. It's a great answer. So why don't we jump to answer some of the questions that you got, Chad?
Yeah, sure. Okay, no problem. Well, before with that, real quick, I wanted to bring in Ray here because he's been sitting patiently in the background, and I wanted him to tell his experience a little bit. So, as you guys know, I'll just tee him up for a second. Ray is an ex-Navy U.S. SEAL, was in the line of duty for a long time, has worked for alphabet agencies, has an amazing background of travel and performance for those alphabet agencies around the world. And he has, in the presence of, being under fire and doing all the things he's done, has used synthetics. He's used, stuff that he's gotten in different regions in different parts of the world, because again, he's like one of our elite, he is the most elite, fighting forces that we have. So a lot of those guys are doing whatever they can to get an edge. So, he has a lot of experience in self-experimentation to be, the super soldier that he was and technically still is. He's a pretty swole guy. But I think he lends a lot of credibility to the kind of treatment and care that Dr. Osborne provides. by telling his story a little bit.
You know, I've used 3 different TRT facilities, and I actually had the privilege of putting Doc through some training, and that's how we became friends. So kind of a unique situation of how we met, but overall, the end solution was fantastic. So I came up to him, started talking to him, explaining what was going on because I found out who he was. And the first thing he said, just like he told you, is, what do you know about TRT? And this is what I know based on the other 2 visits that I've had. They want to put you on as many drugs as they can. Growth, Samoralin, Winstrol, Deca. They want to put you on everything. They don't care if you need it or not. See, the thing that I was almost mesmerized about Doc is he said, the first thing he said was, after you educate yourself, I'm going to bring you down, we're going to take your blood work, and we're going to see if you qualify.
And you're like,
and I'm like, what the hell do you mean, see if I qualify? I'm 43 years old. I've been told, you know, 3 times that I need this. And he was like, has anybody ever really went over your levels? No. Then, you know, why are you doing this, this, and this, and this, which was growth and this and that? Because he said, have you really done your homework on it? I looked at him and I said, no, sir, I haven't. He said, well, before we go any farther, and before I put you in any contact with me, with my nurses, you are going to do some research on, you know, the fundamentals of what it takes to qualify to be on the TRT, you know, replacement system. And I said, okay. So I did my homework and I read it up and I got a little knowledge. Well, you know, and the educational levels, you know, here are a little different, but he gave me some literature that I could understand. And then, you know, I called him and he kind of gave me a little Q&A test, which I thought was phenomenal. Flew me, you know, I took my blood work. He was right on. He literally looked at me and said, it's going to be this, this, and this, brought me down, explained everything to me. And what was so wonderful about it is when he explained it to me, I already had a basic fundamental baseline of what was going on. So I wasn't sitting there just shaking my head, yeah. And he said, okay, now this is what we need to do. We need to get you off this, this, and this, and this. And I'm like, no, well, wait a minute. That stuff cost, growth was costing me $275 a week out of my own pocket. And he looked at me and goes, you don't need it. I'm not in it for the money. I'm in it for your health.
Right.
And that right there, when he told me that, I am not a salesman. I'm not. I tell it like it is. From that moment on, we became friends. He introduced me to Jay. And I said, I want to be a part of this program because you guys are putting people's safety first and you're doing it right and you're educating them. You know, I'm not going to go on and on and on about it, but every day, you know, I'm reading blogs. I'm part of the SOAR team and I'm learning something new every day. And these guys, they still give me Q&A. And, you know, I do good on some things. I'm still learning on other things, but it's a learning process, guys, you know, and it's continuously expanding and progressing. You know, I want to be the best me I can, you know, so, and I know everybody that's listening right here wants to be the best they can too. And if that's what you want to do, these are the guys to make it happen.
Awesome, man.
I'm going to sign off with that. Thanks, guys. Appreciate your time.
Thanks, Ray.
Thanks,
So,
Ray.
I'm gonna jump into the questions. Dr. Osborne's in the background, so he'll walk up. I'm sorry a little bit for the it's kind of discombobulated.
No, this is great, man, and it's one person at a time, changing lives, man, which is great. And I love what you guys are doing.
It definitely is, man. I mean, we definitely have to take this, you know, this whatever you want to call it, you know, our program and our message and our directive, you know, to the masses, and I believe we will. So I'm gonna jump in. I got a question for you. Just go ahead, sit there. I've read somewhere that doing cardiovascular training helps reduce hematocrit levels. Is there any truth to this?
Helps increase
No,
hematocrit?
decrease.
Helps decrease hematocrit levels.
Does it?
No, actually, you know, I'm not aware of any studies to that effect. What it does do is altitude training, first of all, let me preface that, will increase what's called your red blood cell mass. There's no question about it. But what it also does, and probably more importantly, there's this biochemical explanation. I'm just going to make it very, very simple. The affinity for oxygen, hemoglobin's affinity for the oxygen is changed by virtue of the training type that you're doing. So if there is more demand, as an example, for tissue oxygenation, as an example, at high altitudes, the hemoglobin molecules are going to be more apt to, by virtue of biochemical change at the level of the red blood cell, release that oxygen to the tissues. So you do have these physiological adaptations within the red blood cell itself in the context of altitude training. As to whether or not exercise endurance training unto itself increases or decreases red blood cell mass, I'm not aware of any. I'm not aware of any data, but you will shift your what's called your oxygen saturation curve based upon the availability of oxygen during exercise. And again, that's why runners and cyclists will often go to high altitudes and train and then come down and right before race day, because their physiology is sort of better primed to oxygenate the tissues. So, and in addition, they're going to increase their red blood cell mass as well. And it's the same reason why cyclists use epogen or EPO, because all that does is that stimulates the formation of red blood cells. So if you have more red blood cells within a certain volume of vasculature, your oxygen carrying capacity is going to be higher. So you're going to be more tolerant of or less apt to fatigue. So that unto itself is certainly no reason to start exercising. If they're worried about TRT associated elevations in hemoglobin or hematocrit, however you want to measure it, the solution is not to start exercising because you're worried about your hemoglobin going too high and you're using that to counter it. You don't worry about that so much, because what we do with those individuals is one of the lab values, and Leonard had mentioned this, Dr. Farber had mentioned this, we're always checking, and then making a modification. So when you come back to the office, I'm always checking a CBC, which has a hemoglobin and hematocrit in it, and if I don't like the way the numbers are going, and my cutoff usually is around 50 or 51 for the hematocrit, then I'll just have somebody go get phlebotomized. And my nurse sets the patients up for routine phlebotomies, and we like to keep individuals' hematocrits below 50. So I'm not sure what prompted that question, but it may have been, well, if I'm on testosterone, do I need to do endurance work to keep my hemoglobin down? And the answer is well, we can always phlebotomize you, but you should still be doing that endurance work. But I'm not recommending nor endorsing 100-mile runs every week.
Right. Phlebotomy, Scott, is you have your blood drawn. You give blood.
Sorry.
Give blood.
Yeah, bloodletting.
Blood what?
Bloodletting, giving blood, like basically having your blood donated. You're donating blood.
Okay.
That's what phlebotomy is. So that's actually a really good question. I think we should segue into that. One of the things, again, heavily covered in the book, not an issue at all. Some men do on a supplemental form or for dosage of testosterone have elevated hematocrit or hemoglobin, which is red blood cells. And as Dr. Osborn said, the easiest and most simple solution is to be routinely phlebotomized. So basically, you're going to be giving blood like what sometimes guys doing it twice a month, right?
If need be, yeah, absolutely. And I mean, of course, one of the other things that you can do is you can modulate the dose of testosterone, and it may not drive the red blood cell mass up that high. That said, a lot of individuals just sort of sit around the high end of normal, at least my normal, which is 48 or 49 for years, and typically doesn't move, and we just leave them alone. And no issues. But you do have some individuals who are, for whatever reason, particularly sensitive, and those individuals do, as Jay said, require routine phlebotomies, and that may be twice a month. It may, I would say it's usually not that high. But I would say I do have a good number of patients who are phlebotomized on at least a monthly or 6-week basis. And that's not an uncommon situation, nor is it a contraindication to you being on testosterone. It's just one of these things that you have to deal with. That said, your endurance capacity is going to be better when you are on testosterone, because your red blood cell mass, like if you were on epogen, your red blood cell mass is going to be higher. So you're going to have more oxygen carrying capacity to your blood. Of course, the potentially, the downside of that is that if you let it go too high, then potentially your blood cells get a little bit more sticky, and that's why we're pretty aggressive about phlebotomizing patients if they get a creep over 50. So
cool, awesome answer. I got a bunch of questions. I'm going to roll through the ones I think are most relevant. Some of these you can't really answer because of doctor-patient confidentiality. I think I'll just paraphrase. My girlfriend is a former competitive bodybuilder. She's well versed in the use of synthetics. She is totally supportive of my TRT and respects the fact that I am doing it in an open and honest and legal way. She would like to get into a program of HRT for herself. Do you have a lot of former pro athletes or fitness competitors come to you for guidance, Dr. Osborne?
Yeah, I mean, I do have my share of individuals who were engaged either at an amateur, collegiate level, pro level. They're starting to trickle into the clinic, and again, this is fairly early on.
Yeah.
Right now, in other words, as far as the name getting out there, I don't have any issues treating athletes, people that have used or abused synthetics in the past. They may need a little bit more of an aggressive sort of kickstart if they're very, very suppressed, and I do have that with some individuals who come to me having been on synthetics with total testosterones of 50. So despite the fact that they may be enormous, from a muscular standpoint, having abused all these synthetics, they're completely suppressed, and they need to have sort of the endocrine system kickstarted, and I'm well versed in that as well. So I don't have any issues treating them. They're really no different than anybody else. You just have to pay attention to the endocrinology and the physiology, and everybody's really the same. So
right. So for anybody who does watch this that is a competitive bodybuilder, fitness athlete, you've abused synthetics. And Scott, when we talk about synthetics, we mean anabolic steroids. That's what the media talks about them. But basically, they're synthetic analogs of testosterone. All steroids, all anabolic steroids are all some form or derivative or synthetic form of the actual testosterone parent molecule. So anyway, they classify, there's two forms, androgenic and anabolic. I'm not going to get into it. It's discussed in the book. Couple more questions. A good one, I think, is I know some guys that cruise, and obviously these are probably guys that aren't on using the doctor, but whatever, they're gray market people. They cruise with 250 milligrams of testosterone cypionate per week, and they feel that this is their sweet spot. Do you think that dosage is okay, borderline, or too high?
Right. So, and that's a good question. I do have patients coming to my office, and there are some legal ramifications of to this answer. Basically, by law, we are obliged to monitor individuals at certain, and this is state dependent, at certain intervals. And basically, at least my criterion, if somebody were to come and do an audit, in the office, there's absolutely no way that I'm going to have guys running around with super physiologic levels of testosterone. Sometimes patients' total testosterone creeps up slightly over that normal range, and that may be what is necessary to keep their free testosterone. There are two different types of testosterone. Total testosterone is the testosterone that's floating around in your system, bound and unbound. Okay, so bound by plasma proteins and free in the tissues, and then you have the free testosterone, which is the biologically active form of testosterone. That's the stuff that's going into your cells and doing its so-called work. So if I need to get somebody sort of to their optimal number, which is at the edge of that range, and it does take 250 milligrams of testosterone cypionate, that's fine. But they're not going to come to my office on saying that they're in their quote-unquote sweet spot, with numbers of free testosterone that are twice that high end of normal. That's just not going to happen. It's illegal, and we're not in that business. We're not in the business of bodybuilding. We're in the business of health, and I'm not going to push the levels up to those levels of a bodybuilder, because again, that's not the goal of this.
Yeah,
okay?
I think great answer, Doc. I think, Scott, and to the guy that answered this question, thank you for the question. I think the answer is somewhere between 150 and 200 milligrams a week. Okay, I think the 250, for some guys, again, everybody's different, right? We're going by blood panels. We're doing this legally. We're doing this clinically, but the dosage, the sweet spot dosage, at least in my experience as a 14-year TRT patient, Doc's been prescribing for a decade. The reality is that you are somewhere in the range of 150 to 200 milligrams a week to get you to the high end of the normal range, okay? That can be defined differently for some people, okay? And what I mean by that is you could be a 25-year-old guy and have natural testosterone levels of 11 or 1200, right? You just have high natural tests. You have high free test conversion. Remember at the beginning of the show, Dr. Osborne was talking about free tests and total tests. And then 10 years later, you have 450, right? So 450 for some people, they function fine, but for a guy who's normally double that, and now 10 years later has half of his natural testosterone levels or production, well, guess what? He has low testosterone. But as Dr. Osborne has said in the book, again, clearly substantiates this, you're always going to treat the clinical conditions and clinical symptoms of that individual patient first. It's not just the blood levels. It's the symptoms. It's him evaluating you and finding out who you are. Okay, so I think that's the best answer. You know, there is no sweet number, but if we were gonna, you know, if somebody put a gun to our heads and say, what was the average dosage to get the average guy in America or anywhere in the world to be at, you know, a high normal range of testosterone, functioning optimally, good libido, good energy, no mental fog, we would say between 150 and 200 milligrams a week. One more question. Are you going to cover the use of nootropics in your book, Get Serious Volume 2? I use modafinil to help increase my focus and energy.
Right, and that's another good question. I did talk about it in the first iteration of the book, basically, and it is going to be addressed in a more robust manner during the second iteration of the book. Yes, absolutely. As far as the modafinil is concerned, yes, it does. There's experience, military experience with this medication. We're not quite sure of the mechanisms of the of action of the medication, but I will tell you that it's not a medication that causes tachycardia or rapid heartbeat or palpitations like some of these other caffeine-based stimulants do. Again, the mechanism is unknown, but it doesn't have that effect. So, you know, it's one of these things that has not been endorsed by the FDA as something that is, you know, as a nootropic, so to speak. I mean, the indications for using it, and I'm telling you, as a prescriber of it, are individuals that work sort of shift work. So they have sort of the light dark cycle flipped, and they end up getting tired during their shift. We use it for that. Some people use it for jet lag, although I don't believe that that's an indication for it. And the primary indication for these things is for vigil is, and this is just this is the sort of the generic or one of the analogs of it, is narcolepsy. Right. When patients have a tendency to just fall asleep. So right now we're not endorsing these things as nootropics. Do they work? They do work. We know that. And in Europe, there's more liberal prescribing patterns, right. And a lot of these, and I did talk about this a little bit in the book, and a lot of these medications that we're using as anti-epileptic drugs, Dilantin, there's another drug called Depronil, which are prescription strong centrally acting medications are being used to enhance potentially focus and cognitive abilities. But the modafinil does work. There's no question about it. The side effect profile is basically that of a sugar pill. Okay, it doesn't have the associated right. side effects, you know, of the caffeine-based stimulants, tachycardia, insomnia, et cetera, et cetera. You know, I'm talking about. I shouldn't say that. Not insomnia, but the problem with a lot of these stimulants that are caffeine-based is that these medications, they will literally wire you. Right. And yes, and that's another thing. There is withdrawal, which is really not the case with modafinil at all. There are a whole host of side effects associated with these caffeine-based stimulants that are not seen with modafinil. So it's a relatively speaking, it's a safe drug.
We'll talk a lot about modafinil and Get Serious Volume 2. I have one last question, Scott. I really appreciate you staying late for us today.
Oh yeah, no worries.
I think this is an amazing question, by the way, and I think that this is a question that I'm going to glorify on our blog because I really think it's kind of like the symbiosis. I mean, this is like the kind of, you know, for anybody who watches our show, anybody who's a potential SOAR candidate, anyone who, you know, is contemplating, you know, fixing whatever it ails them. And again, this is mostly for men, but this does apply for women too. So I'm going to ask the question. I want you to answer it. So I find men who are most in need of test replacement there are often the least receptive to it. What I mean by that is, how often do you see a man in his 40s and 50s who is afraid to go on TRT for whatever reason? Maybe it's his spouse, maybe it's the media, but then does go on TB or TRT, excuse me, and has what I would deem a midlife awakening. And they absolutely get busy living their life with purpose and passion. I am saying this question or asking this question for Dr. Osborn because I was one of those men. And I would like Dr. Osborn to give his opinion on what life is like pre-TRT, again, assuming that a person qualifies to go on TRT, and post-TRT.
Right, and we see patients like this in the practice fairly routinely. I will tell you that for me, personally, and this is something that I try to portray to my patients, the difference between individuals, and I'm talking about mentally, physically, et cetera, sexually, whatever. The difference between being on and being off is nothing short of dramatic, and is oftentimes a life-changing event. It's a life-changing event.
It's a game changer.
Yes, it's a game changer. Wholeheartedly, it is a game changer. So that's the only way I can describe it. I usually tell patients that it's nothing short of dramatic, and I think I say that 1,000 times in my office per month. Okay, in this regard. So that's what I would say. And the problem is this. Unfortunately, due to media stigma, the bad press, whatever you want to call it, and lack of education, and an individual's lack of motivation to really seek out the truth, we have this problem in this country. And the amount or the number of males that are actually truly being diagnosed with hypogonadism is just a fraction of the individuals who actually have it. Because let's face it, and it's a chicken or the egg, and I think chicken or the egg phenomenon. And I think I've been through this with you before, Scott. You know, it's either we, as a function of our age, develop hypogonadism, or we age because our hormones are going down. Right. So it's going to happen.
Either way.
And I'm not going to say this, use the exact sort of phraseology that I use with Jay, and Ray's probably heard me say this, but if you are 35 years of age and you have not seriously considered this thought hasn't entered your mind yet, you are, wake up. Those are not the words I use, but yeah, wake up, because it's going to happen to you. It may not be at 35, okay? It may be at 45, it may be at 50, okay? Where you become clinically a candidate for testosterone replacement therapy. Most people think that, as an example, that menopause occurs in women that are 50 and up. But we know, the anti-aging physicians, if you go to any of the anti-aging meetings, or you ask an obstetrician, they will tell you that hormones, particularly progesterone levels, start going down in their 20s. Right. 20s. Right. So this is happening. Whether or not, again, it's a function of age or the opposite, we don't know, okay, but it's going to happen. So people just need to get on the ball.
Absolutely, that answer is awesome. I mean, honestly,
that was an awesome answer.
Yeah, no, I mean, honestly, you know, we'll sign off with this, but for any of you guys who watch our show, you know, who listen to this, who read the transcripts, you know, who are frequent visitors to our blog, if you are in your late 30s, okay, and again, for some of you guys, you know, like you, Scott, even in your early 30s, who feel like you may be suffering from some of the signs and symptoms of low testosterone, and again, educate yourself as to what those are. My book will do a great job for anybody when it does come out, but it's not out yet. It's still a couple months away, probably, or less than. Do yourself a favor and get your blood drawn, okay? Do your homework, do your due diligence, understand what you're personally dealing with. And hey, look, if you've got a low blood testosterone level, and I'm not going to say what that number is, it's different for different people, but if you're suboptimal and, you know, it comes back and it says this is low testosterone, and if you have a doctor who examines your labs, whether they're a competent physician or not, most doctors can at least tell you if you have low testosterone. But if you have, you know, under 500, under 400, under 300 levels, and you also have all the symptoms, my God, don't wait for it to get worse. Okay, there's no reason. There are doctors out there like Dr. Osborne. There are people out there like myself that you can come to, and we can push you in the direction of seeking help. I mean, there's to me, and obviously Dr. Osborne agrees with me. There's nothing worse than suffering with low testosterone. There's no point. And as Dr. Osborne said, it's unfortunate that so many men literally are suffering the symptoms and don't even know about it because they're either embarrassed, they're humiliated. Again, the media has demonized the subject to the point where it's like it's a stigmata to go around and tell people that you use TRT. It's a joke. I mean, any woman can go to any woman's doctor and say, look, doc, I want my hormones optimized, and it's no issue. They write a script for progesterone or estrogen cream or whatever, even testosterone sometimes, and it's not an issue. And women do it all the time, everywhere in North America, in the Midwest, everywhere. But for a guy, it's like this. Scarlet letter, it's like, oh, I don't want to tell somebody that I'm using testosterone, or, the media tells me that it's dangerous, or I could get a heart attack or die of a vascular event. I mean, it's all BS, okay? So again, you guys watch our show, come to our website, read the things that we continually tell you about, but the best strategy is to be informed, to do your homework, and then assuming that the symptoms show up and you are suffering in the way that we think you may be, because many men are, reach out to us and we can help you.
Sweet.
Cool. Do you have anything else, or are you good?
No, I'm going to say bye. Thanks for watching, everybody.
Thanks,
Thank
Scott,
you.
for hanging. We'll see you in a couple weeks.
All right, guys. Have a great time.
Bye, guys.
Yes.
See you, brother. Thank you, man.